Hussein Sheashaa. Professor Hussein is a professor of nephrology in Mansoura University, and he's the dynamo of the continuous medical education in the board of the Egyptian Society of Nephrology. Professor Hussein will talk today about 2019, what's new in hemodialysis.
First of all, thank you very much, Professor Muhammad Salah, for this kind introduction. It's my pleasure. It's always my pleasure and honor to participate in it with Ain Shams team. It's my honor and pleasure. And I would like to thank all the team, especially Professor Mahdi Sharawi and Professor Shams Said for their kind invitation. It is very difficult to speak about the publications because I reviewed 1,800 articles that were published within the last 10 months. And from the hemodialysis, there is 400 articles, and they were prepared in 400 slides, and I'm going to present and share with you some of them. To start with, chronic kidney disease is very bad news. So we should think of chronic kidney disease prevention to retard the progression. If you look here, this is the outcome of cardiovascular disease and stroke and chronic kidney disease regarding mortality and the cost. Chronic kidney disease is the same like cardiovascular and stroke. And if it is severe chronic kidney disease, mortality is more and more. So chronic kidney disease is one of non-traditional cardiovascular risk factors. One of the important conferences is the KDIGO Controversy Conference. And one of the best messages regarding dialysis initiation, modality choice, access, and prescription is no one size fits all. And we should individualize our treatment according to the patient preference and facility. Let us start with the first point regarding diabetes. If we have end-stage kidney disease in a diabetic patient, which is the best, hemodialysis or peritoneal dialysis? The answer, according to this meta-analysis, HD is superior in outcome to BD in diabetic end-stage kidney disease patient. But for my impression and my evaluation, neither HD nor BD, the best renal replacement therapy is transplantation whenever possible for diabetic patients. The registries give us a lot of information. This is the European registry that was released from 36 countries. And as you see here, the incident patients renal replacement therapy for diabetes, hemodialysis is 85%, and non-diabetes is 80%. And the prevalence, 2/3 of patients of diabetic end-stage kidney disease are replaced by hemodialysis versus 45% of non-diabetic patients. So hemodialysis is the most common modality in diabetic patients. And this year, we have the birth of Egyptian renal data system. And this is the nice board led by Professor Maya Hassaballah. And always we have meetings. And Professor Mahdi Sharawi will join us. And I hope Professor Shams said also to make this team to enrich the efforts. Every week we have meeting, and this was the last meeting in the 4th of October to refine the template of Egyptian data system. Let us go back to diabetes. Can we optimize the management of diabetes? Yes. The best optimization is to monitor the patient safely to avoid hypoglycemia. This is through closed loop. It is pilot study, include, as you see here, a lot of readings, and the readings are sent through the phone and it can be monitored. So this is the best way to reduce hypoglycemia. So continuous monitoring of plasma glucose is considered the best, but still, this is a pilot study and we are waiting further studies for this point. Bariatric surgery in end-stage kidney disease. Is it there? Yes. Many patients, obese end-stage kidney disease patients, are subjected to bariatric surgery. Through the years, there is increasing in sleeve gastrectomy. And this is a very assuring data about the cohort of patients, including a large number of patients. The trend of bariatric surgery increased ninefold in the current era. And as you see, to the comparison to patients who are subjected to bariatric surgery, comparing end stage versus non-end stage, there is no difference in complication, length of stay, but in this cohort, there is increased readmission in end-stage kidney disease. This is an assuring cohort of patients, but there are many reports showing adverse outcome of bariatric surgery in end-stage kidney disease. Let us go to funny data. Who live longer, females or males? In general population, females live longer, but in dialysis, this is one of dialysis paradox. Females live shorter. So why? Because they may be subjected to bias in starting dialysis. Dialysis start late in females, and they were subjected to less intense dialysis. So long as we are speaking about females, what about pregnancy in end-stage dialysis? Pregnancy, this is the larger number of cohort, 2,300 pregnancies. One of the important messages is pregnancy is less frequent in BD. Why? The question is why? Why BD is associated with less successful pregnancies? Because of peritonitis and mechanical issues, to the extent that it may be wise for females who are thinking of pregnancy to start through hemodialysis. KT over V for dialysis prescription. Is it the holy grail? Although I am interested in KT over V, and we have publications since more than 20 years about KT over V and neuromuscular function, but nowadays there is increased trend toward reducing the value of KT over V, as Professor Hisham said, always saying, and this is a very nice title, as one song, this means approximate the end of KT over V. We shouldn't say this, but it is a parameter of follow-up. KT over V is invalid in the following sectors of patients: in women and small men, in fluid overload, children, elderly, obese, diabetic, pregnancy, race, and the patients with residual kidney function. So this means that we shouldn't depend solely on KT over V to adjust dialysis. Yes, dialysis, we need access. So this is one of the randomized controlled studies about the VASQ, which is the style, this is apparatus, this is device, improve the patency of the fistula. And one of the important points, this is the data in acute renal failure. Replacement of using the catheter. Is it tunneled or non-tunneled catheters for treating acute renal failure? Usually we do non-tunneled temporary catheter. But look at the change in the paradigm of thinking. This is one of the most prestigious hospital, Brigham and Women's Hospital at Harvard. They have a checklist for patients with renal failure, acute renal failure. If they fulfill certain criteria, non-tunneled catheter is not the choice, and the tunneled catheter. Why I am putting the data of acute renal failure here in this slide, just to declare and to confirm inappropriateness of temporary catheter for prevalent dialysis. So we should stop this habit, because the data register of Shams for more than 20,000 patients, 95% start through temporary catheter, and this is, I think, it is shame for us. Regarding vascular access, this is one of the most important guidelines that is released in June this year about, and we discussed it at our meeting of the Qahlani Furj group by Professor Tariq Medhat. Was very nice presentation that is uploaded to the site of the Virtual Academy from Professor Tariq's slides. The guideline discusses all these points, and just one or two statements from the guidelines. The use of antibiotic as pre-operative prophylaxis is recommended for AV graft, suggested for complex fistula, and no need for prophylaxis in simple fistula. The same here, we should not cannulate the fistula below 2 weeks. Again, this is a recommendation. I enjoyed this presentation. Also, the use of cocktail of drugs like warfarin and antiplatelet, or combination of clopidogrel and high-dose aspirin should be taken seriously because of the risk of bleeding. And if you wanted to see the slide, this is the slide of Professor Tarek Milhat at the Virtual Academy. Surgeons, we should collaborate well with the vascular surgeon, and we should select the best hand for fistula, because fistula is not vascular access for dialysis, it is line for life. So among 5,000 surgeons who placed more than 400,000 axes, fistula in 70%, and as you see, maturation of fistula, it is the most important factor, is dependent upon the volume of fistula creation. So surgeons with high volume of replacement are skillful and enjoying successful maturation of the fistula. Sometimes fistula is not always the best, because in this study the graft is associated with shortened catheter. In elderly, is the fistula the best? According to this data that included large number of elderly patients, 1 year, 2 years, 3 years, up to 5 years survival, if catheter is persistently used and the vascular access, mortality is higher, survival is lower with catheter. So to the extent the authors recommended AV fistula for elderly patients with a life expectancy more than 4 months. Again, is it always the best? The answer is no, because I agree with this review about should fistula first policy be revisited in elderly? Yes, should be revisited, and we should look at the patient characteristic. So we follow patient-centered approach, looking at the patient characteristics and the facilities that we have. So if we have a patient with slow CKD progression, adequate vascular anatomy, good functional status, few comorbidity, and life expectancy expected to be more than 2 years, the best vascular access is fistula. And if there is rapid CKD progression, high risk of failure to mature of fistula, so graft is the first choice. If there is multiple comorbidities and a short lifespan, catheter may be the best vascular access. If we are obliged for catheter, because sometimes it is the only access that can be done for the patients, we should take care of that we have technique. So next slide, HD catheter. This is 100 study included 115 hemodialysis patients at 6 sites, 10,000 days with a mean duration of 95 days. And this is the catheter. The infection reduced the standard as recommended to be less than 1 per 1,000 catheter days, and with the use of next side HD catheter, it was reduced to less than 0.64 per 1,000 catheter days. One of a very interesting catheter lock, which is sodium bicarbonate. I think it's very cheap and available to use concentrated bicarb, 10 milliliter for each catheter board. And in this study, they found that in comparison to saline, the use of sodium bicarbonate as lock solution for the catheter reduce thrombosis and infection. And that because why? Because Professor Hisham say why? Because sodium bicarb has anti-infection and anti-thrombosis. But up to this moment, we don't have the goals, the best catheter look. We are totally against the use of antibiotics, but we may use antimicrobial because antibiotics increase resistance. Regarding GFR and initiation of dialysis, this is a study in children. They compare starting with higher estimated GFR above 10 or less than 10 in children. Who acquired the best survival? This is a trend. Through the years, the pediatricians started dialysis earlier with higher GFR. But the outcome is that, as you read here, there is a trend toward the higher estimated GFR at dialysis initiation, but higher estimated GFR at dialysis initiation is associated with lower survival. So there is no need for this, except if there is indication. As we speak about children, what about growth? We shouldn't deprive children from growth hormone therapy whenever it's indicated, because the uremic environment is full of factors that lead to growth retardation. But the question, what are the contraindications of growth hormone? This review includes 8 contraindications. I want to concentrate on only 4. So if we have severe hyperparathyroidism above 500, and we will hear from Professor Amr tomorrow, inshallah, about the parathyroid and the CKD and BD. So the severe hyperparathyroidism is considered contraindication for growth hormone therapy. In patients with proliferative or severe non-proliferative diabetic retinopathy is considered contraindication for growth hormone therapy during the first year of transplantation. And I'm not sure why in the first year it may be induce sclerosis, I don't know. But the best strategy in the first year of transplantation is to avoid steroid or to use the lower steroid as we can, because sometimes the immunology risk dictate the use of steroids. The fourth, in patients with active malignancy, because we are afraid of increasing. So you can visit this article to look at the details of growth hormone. Incremental versus conventional dialysis. In this study, and in survival advantage was there for incremental dialysis because it preserves residual kidney function and allows smooth start of dialysis. And this is the very recent, this is the current issue, showing this is the title and the very nice review. And I want to just say a statement here. We are careful about starting incremental hemodialysis if the patient's situation is okay. If there is hypervolemia, overload, malnutrition, it doesn't matter to keep residual kidney function, we should do dialysis intensively. So incremental dialysis is the best, whenever safe and possible. Regarding the medium cutoff membranes and high flux dialyzers. This is a randomized controlled study and crossover, including few number of patients in each arm, 20 and 20, and this study recommended, and it is axiomatic and logic that the use of medium cutoff membranes will get rid of myoglobin and other uremic toxins, but we are waiting further studies to prove the benefit of using this high cutoff or medium cutoff membrane. One of the important articles that I like, the non-invasive modality, this is whole body bioimpedance. And in this study, they assess the cardiac power index and the total peripheral resistance index, and they follow the approach. So if we have a patient with initial hemodynamic assessment in hypotensive response, normal response, or hypertensive response. If there is hypotensive response, according to low cardiac power index, if there is systolic or diastolic function, we go through these medications. If there is low peripheral resistance and autonomic dysfunction, we prefer dialysate cooling. If the patient is hypertensive and with elevated sympathetic activity, we use adrenergic blockers. If there is high cardiac index and hypervolemia, we should tailor the treatment to decrease the dry body weight. We encourage the use of facilities like ultrasound of the lung, IVC, and this is what we do routine for our patients at the Urology Referral Center for the hemodialysis patients to augment the clinical assessment by IVC diameter and the stability index. I'm interested in echocardiogram, and this is why we include it in all international hemodialysis courses done at the center with the African trainees. Point of care ultrasound, this is very interesting. Regarding cold dialysate, I think it is a smart modality that is usually overlooked. So calling the dialysate reduces intradialytic hypotension. Regarding this study, this is 7-day monitoring of ECG. And the key message from this study is whenever the interdialytic period is long, arrhythmia is there. And this study proved from autonomic profile that frequent dialysis is superior to prolonged interdialytic period. Hypertension, we should encourage volume first approach, and tomorrow or Saturday we will hear from Professor Donia about evaluation of the volume status. So before adopting a rushing attitude to give antihypertensive treatment, we should evaluate the dry body weight, individualize dialysis sodium and restrict sodium, because up to this moment, we don't know which is the best blood pressure for dialysis patients. So it is better to stop a while, review the body weight, and then start medication. What about beta blocker? This is one of the studies, and this is the systematic review and meta-analysis documenting the advantages of using beta blocker in dialysis patient, reduce mortality. But I want to just to add two statements here. If the patient has intradialytic hypotension, the carvedilol is not good drug, because there is a study comparing metoprolol versus carvedilol showed higher mortality with carvedilol because it increases intradialytic hypotension. If the patient has intradialytic hypertension, carvedilol is the best because it is either non-dialyzable or negligibly dialyzable. Intensive hemodialysis may be effective against pulmonary hypertension. Regarding anemia, I think that the time is not in this month in the New England Journal of Medicine. We have two articles about roxadustat, which is bromolyl hydroxylase inhibitor for patients prior dialysis or dialysis patient. The same result. These are two studies. Hemoglobin is increased, and in the same moment, hepcidin is reduced because bromolyl hydroxylase inhibitor have their anti-inflammatory effect. And this is a very interesting review about the bromolyl hydroxylase inhibitors showing the state of this class of drugs. Regarding cancer, should we use ESA with cancer? We are afraid of increased progression of malignancy, thrombotic risk, worsening hypertension, increased stroke. So this another article showing summary of the American Society of Clinical Oncology and American Society of Hematology Clinical Practice Guidelines update. ESA may be offered to patients with chemotherapy-associated anemia whose cancer treatment is not curative in intent and whose hemoglobin is less than 10. And blood transfusion may be an option. For patients with multiple myeloma, non-Hodgkin lymphoma, and chronic lymphocytic leukemia, clinician should observe the hematologic response before considering an ESA therapy. This is a very interesting statement here. We should look at the history, if there is history of malignancy or not, before prescribing ESA therapy. Physical evaluation. This is an ultrasound of the muscle. Here, the more the worsening of the kidney function, the more the efficiency of the muscle. So we can know the composition of the muscle from ultrasound before waiting until muscle wasting. Why there is increased echogenicity here? Because either accumulation of fat or fibrosis. So it is myofibrosis or myosteatosis. Exercise is good, and we should encourage exercise. And there are many benefits for doing the intradialytic exercise. And this is one of the questions that was targeted by this systematic review and meta-analysis. Does intradialytic exercise improve removal of solutes by hemodialysis? The answer is yes. Exercise improves solute removal and increase creatinine excretion. Regarding cognitive impairment in dialysis, it is very common, and this is one of the approaches, intradialytic cerebral hyperfusion, that can be assisted by transcranial Doppler, MRI or CT or spectroscopy. And these are the interventions. Cooling of the dialysate, treating depression can be valuable intervention to guard against this issue. I'm not going to speak about CKD-MBD with the presence of the Professor Hussein, but this is one of the interesting chapters about CKD-MBD and Chinese guidelines. So I skip all these points. Tinabanor, I like tinabanor because, but we are waiting further evidence. It interacts with sodium hydrogen exchanger, so it helps to get rid of sodium and phosphate. And this is the result. Phase 3 study documenting the tinabanor is efficient in reducing serum phosphate. In the ESOT, we have an oral presentation from the Urology and Reflux Center about the parathyroid disorders after transplantation. Post-transplant hyperparathyroidism was documented in 54% of patients. And the status of hyperparathyroidism before transplantation was an important risk factor for post-transplant. And one of the questions in the discussion was, what about parathyroidectomy? And I think it will be covered tomorrow by Professor Amr Hussein. And these are 3 articles discussing the timing of parathyroidectomy, and up to this moment, we are not sure which is the best time. FGF23, the higher the FGF23, the higher the muscle index and low ejection fraction. And one of important drug that is tested in X-linked hypophosphatemia is Bersumab, which is molecular antibody that reduces FGF23. And this is a very recent experimental study documenting interconnection between FGF23 and inflammation. So we can target FGF23 by blocking cytokines. We are waiting studies. What is TOT? This is topical oxygen therapy that can be used for the caring of wounds in dialysis. And this is the chamber that is put all through the dialysis session and help regeneration of the wounds and the healing. We should look at potassium because it is not only hyperkalemia, but hypokalemia is bad. Hypokalemia before and after dialysis, both of them are associated with higher mortality. I go through, I omit some slides because of the sake of the time. Thyroid disorders, hypothyroidism is common, 14%, and Professor Mujahid will discuss it, but it's associated with higher mortality. Carpal tunnel syndrome was associated with increased blood lead level in hemodialysis patients in this study. We should take care, the last points, regarding gadolinium, and this is a question from Professor Hisham to stop speaking with Dr. Amr. Regarding gadolinium and nephrogenic systemic fibrosis, what is the state now? The state now, we shouldn't be afraid of nephrogenic systemic fibrosis. Why? Because it was proven to be linked to an old gadolinium formula, which was gadolinium that we stopped it from the origin fluorescent. And these are the types. Gadolinium is non-ionic linear, which is associated with large number of cases. And from 2008 up to this moment, few cases reported about this issue. The Canadian guidelines showed that we have different members of gadolinium. They are classified into first, second, and third generation. Nephrogenic systemic fibrosis is not diagnosed with second and third generation gadolinium, to the extent that this is the new guidelines. Informed consent prior to administration of group 2 gadolinium-based contrast agents are not needed. Screening for renal dysfunction even not needed for the new generation of gadolinium. So it was the matter of the old. I skip all these. One of the important points, I think one of the landmark point in the history of Egyptian hemodialysis is the guidelines that is edited by Professor Sheashaa and reviewed from the panel. And we hope that we will witness the practice of this. We should change our mind from just treating and monitoring to encourage the patient to share us. So patient-reported outcome is important, and the hemodialysis sharing to do his best. And I think the best way is to avoid dialysis if we can, because dialysis is associated with poor quality of life and increased mortality. One of the strategies is to encourage preemptive transplantation because it's associated with better survival in living and cadaveric transplantation. And the second axis is to retard the progression of chronic kidney disease, so preserving kidney function is better than replacing kidney function. And one of the strategies is to enhance the public education. So this is one of our goals and the tasks from the Dakhliya Nephrology Group is to educate people about the lifestyle and to enhance education, as you see. And I'd like to end لأن مش لاقي حاجة أنهي بها غير أجمل من اللغة العربية. فأنا بحس بالراحة مع جامعة عين شمس، مع الدكتور ماجد والدكتور هشام وكل الناس اللي قاعدين طبعا حبايبنا. فالرسالة دي جت من الدكتورة غادة القنيشي على الماسنجر، فقلت هي اللاست سلايد. فجميلة خالص. زر دار ود إن أردت ورودا. فطبعا الورود عندنا هنا موجودة كتير يا دكتور مجدي. طبعا الواحد ما اتغداش يعني. زر دار ود إن أردت ورودا، زادوك ودا إن رأوك ودودا. أشكركم على حسن الاستماع.
Thank you, Professor Hussein, for such elegant presentation and very comprehensive topic. Any questions? Yes, okay, for the sake of time, we'll move to the next presentation.